Well, hello, I'm Dr. Joanne Hobson. I'm the Clinical Lead Director of the Menopause Consortium, and I'm delighted to have with me today Dr. Bill Robertson-Smith, who works in trauma and orthopedics and has developed an interest in bone health. And really, it'd be great to talk to you because for many years, how bone worked and sorted itself out was an absolute mystery to me. And I had to start learning about it when I became more specialised in menopause. So perhaps we could sort of start from the basis, really, and look at how does bone work? What factors in bone modelling contribute to bone formation?
Well, bone is constantly regenerating and remodeling. It's got two types of cells. So you've got the osteoblasts, which build the bone up, and you've got the osteoclasts, which kind of break the bone down. So really, you just need a fine balance of the two of those for normal, healthy bone.
And so that sounds all lovely. That's everything in the garden is rosy. So it's a bit like one of those revolving hotel doors, isn't it? One guest in, one guest out. But clearly that can get disrupted. And what happens causing decreased bone density?
Well, I mean, there are a number of things. So if you're deficient in calcium, for example, that's essential for bone mineralization. So if you're deficient in calcium, that has a big effect on it. But also if you're deficient in vitamin D, because you need the vitamin D to be able to absorb the calcium from the gut. So that's why that's really important. You could be taking long-term medications like steroids for COPD, for example, lung condition, or for rheumatoid arthritis, or anything really sort of autoimmune.
So all those are sort of factors that influence it. So what do they do? Do they make the clasts cut the bone quicker? Or do they make the builder bones, the osteoblasts, go on strike? So
yeah,
what actually do we know happens in bone?
Yeah, I mean, it just depends whether the fine balance is disrupted. I mean, a really good example of that is for midlife and hormones. So osteoblasts are really important in bone health because they build the bones. And for example, they would need estrogen to be able to stimulate that. And if they don't get the estrogen because our hormones decrease at midlife, then they can't do their job properly. And then the osteoclasts are still doing their job. So we've got a real mismatch between the building of the bone and the breaking down of the bone.
One thing that I think lots of people will be interested to hear, we all make the assumption that we can make our bones much thicker for the whole of our lives, and it's quite surprising to learn that is not the case, is it?
No, I mean, you do need to work at your bone health, because over the course of 10 years, you'll get a whole new skeleton. Bones are living, they're constantly regenerating. And I think that's what lots of people don't really realize. They just think your skeleton is your skeleton, and that's not the case. But you can do lots of things to help your bone health from before midlife. So you can do weight training exercises and really stress the skeleton, because the skeleton likes to be stressed.
Sorry to interrupt, but it was that sort of what I was sort of getting at, because okay, we get all these factors that we all suddenly become aware of as we reach midlife. You think, oh my God, I better do something about it. But it's childhood, isn't it? We need healthy diet and bone thickening exercises, because our peak bone mass it's in our mid-20s or something. Is that right?
Yeah, it's about sort of 10 years after you've reached skeletal maturity. That's when your peak bone mass is. And then obviously it declines really slowly up until midlife, and then it declines really quickly. So it's really important that way before midlife occurs, that really women especially are thinking about that, because 1 in 2 women will get a fracture after midlife, whereas 2 in 5 men will get one. So women are much more susceptible to
that. Those are frightening figures. So, bearing in mind not only the impact that it has on the individual, but the NHS budget, because we've got lots of people in, you must see patient after patient in trauma and orthopedics with a fractured hip, ladies especially, and then that has implications on hospital beds and their return to full function. So how can we've got prevention with all the strategies, but what treatments are available once you've got to osteoporosis? And then perhaps we can look a little bit further back at how we don't get osteoporosis. So what is there to treat it? And how does
I mean, there are three main types of treatment for osteoporosis. So you've got your preventative, and so that's replacing your hormones. So that's a really good one. So your estrogen, progesterone, testosterone. So replacing those in perimenopause is important for your ongoing bone health, as well as your longevity and your health in other aspects like cardiovascular health. There's bisphosphonates, which are mainly given, they're bone strengthening drugs, and they're given for people who have actually got osteoporosis. So that's not really a preventative, but it's for people that have got it that don't want to have a fracture. So they work by stopping the bone from breaking down. So the osteoclastic activity, they stop that. The only problem with taking bisphosphonates, you can only take them for about 3 to 5 years, because they continue to work even though you've stopped taking them. And your bone can get so brittle that you could actually have an atypical fracture of the femur. That's the most common.
So there's a window there, isn't there, where they work? Yeah.
Yeah, there is. I think that 5 years is really the maximum that you can take those. And then you've got
with MHT, of course. Sorry to interrupt.
Sorry, say that again.
You can take MHT for a lot longer. So if you just start your bisphosphonates, it's about timing, isn't it? So sorry, what was the third option?
So the third thing is an anabolic medication. So these are usually given by injection, and they stimulate the osteoblastic activity. So they work in a slightly different way. So they stimulate the osteoblasts to build the bone, but you need to stop these after 2 years. Now, they don't continue working after 2 years, not unlike the bisphosphonates, which continue to work. But you can get osteosarcoma of the bone if you take those for long term. So really the safest option is to prevent this rather than be treated for it.
And probably the one that's got the most longevity in it is MHT, from what you were saying. Yes,
definitely, because you can take it long term. So and it continues to work.
Which is great news. So on the basis that treatment isn't, once you've got it, treatment is not necessarily as good as prevention. I mean, I always believe that prevention is better than cure. So what risk factors come into affecting your bone density, or your final top bone density, if you like? Because once you filled your coffee cup, it's can't go anywhere else.
Yeah, you just need to keep up with the treatments that you've been given. I mean, that's the most important thing. I think once you stop taking treatments, even the bisphosphonates, they're going to stop working after a time. So really to continue to speak to your practitioner and continue treatment, because unless you start your treatment, then things aren't going to get much better for you.
So as a clinical practitioner, you see somebody who may be developing osteopenia or osteoporosis. And of course, I think we need to impress here that, fractures don't occur without a fall. And even if you've got osteoporosis, you don't necessarily know it until you have a fall, if you like, which will precipitate all the investigations. So are there any risk factors that you might think contribute to your bone loss? I mean, I know that my family history is very important. With if you've got a family member who's had a fracture, then that really does have an impact upon your chances of having osteoporosis. Are there any other factors?
Well, you do need to be aware of family history, because it's genetics. But diet, lifestyle, smoking and drinking, they inhibit osteoblastic activity. So your bone won't be able to build the bone that it needs to. So that that's a real detriment, actually. I think the NHS say more than 3 glasses of alcohol or 3 units of alcohol per day. You should limit it to 3 units.
2 if you don't want breast cancer.
Yes.
So I think the other thing that I always think is important when I'm talking to somebody is, do they have any history of any eating disorders, and how many pregnancies? Because those are 2 things that you wouldn't necessarily immediately associate with a risk of osteopenia or osteoporosis.
Yeah, I mean, definitely the eating, because I think that, you know, diet's just so essential, isn't it? We've already spoken about the calcium and the vitamin D. So I think that's definitely something that should be spoken about.
And no, I think we're very much aware. We're hoping, you know, TMC's mission is to, you know, invite, you know, specialists such as yourself to share information and to get the message out there. So, what can a perimenopausal, not I don't want to just stick it with the perimenopausal person. What can all of us do to look after our bone health and in terms of lifestyle? And you know, I think there's a lot about sunshine as well, isn't there? That's you know, you can't have too much, but you have to have a little bit. What are your thoughts on all of those things?
I mean, I think that I would say, even before perimenopause, you need to look after your bones with diet. So we've spoken about vitamin D and calcium. You need to stop smoking, definitely, and just reduce alcohol. You don't need to stop alcohol, but certainly reduce it. When you get to perimenopause age, you need to think about replacing your hormones, as we've spoken about, but also to do weight-bearing exercise and stress the skeleton. So running, walking fast. Even if you can't run, you can walk fast. Stomping up and down the stairs, stomping on the ground, just, you know, marching on the spot if you can't manage anything else. Something is better than nothing.
It's very good to have a stomp if you have a row with a family member and you stomp up and down stairs, and you can think, I'm getting back at you because I'm going to live longer and get my bones up. So one of the things that I remember from a lecture given at the British Menopause Conference many years ago, there was a consultant who was interested in bone health, and he was talking about how we have almost gone the other way to prevent children from being in the sunshine, and we tend to cover them up with a factor 50, with the desert hats on, and you know, in this country, everyone should be on vitamin D from, you know, through the winter months. And I think we do need to go out in the sunshine, because it does, the sunshine helps us make vitamin D. And I think that's the best way to get vitamin D into our systems. But we must be wary of too much sun. So what are your thoughts on sunbathing, in inverted commas?
Oh, well, I don't know too much about sunbathing. I don't go out into the sun very much. I think it's really important to get the sun on your skin.
Yeah, that's what I meant.
Without the sun cream, you know, really important. That. I don't know the amount of time, because obviously everybody has different types of skin, don't they? So I definitely think you should spend some time in the sun without sun cream on, because you need the vitamin D for sure. But you should also be taking it as a supplement.
Yes.
And that's really important for children as well, but certainly for adults. You know, if you think,
go on.
Sorry.
Children don't roll around anymore after school, do they? They come home and sit down and play on their iPads, so they're not getting that bone-forming exercise.
If you go to the NHS website, and they do have dosages for vitamin D that everybody should take. So you can have a look at that, and I'm not sure what it is in children, because there's different dosages for different ages of child. But the NHS does say that we should be having about 400 international units of vitamin D per day, and that's just sort of normal if you're, you know, in and out of doors, if you are healthy. If you obviously, say you were in a care home and you weren't getting out of doors, you probably need more vitamin D, but also you might have other health conditions that would prevent you from having so much vitamin D and calcium. So it's really important to speak to somebody about it. Even the pharmacist would be able to direct you to the correct dosage, but it's about 400 international units.
Just one last thing, because I think we're sort of on the time cusp, is when young women are diagnosed with premature ovarian insufficiency, I think it's important that they are encouraged to have a baseline bone density scan at that time, so that we can watch their bone density very closely, particularly if they are perhaps ambivalent about starting MHT. So I think, bone scans do have a role to play in terms of encouraging people to have the right treatment.
Yeah, definitely. I don't know how easy that is to get on the NHS, but I think that in the guidelines it does say that women with POI should have a DEXA scan. Yes, certainly.
Absolutely. Okay, so that's very kind of you to join us. Thank you very much, Dr. Bill. And I shall hopefully we'll do some more collaboration in the future. Thank you.
Yeah, lovely. Thanks for having me. Thank you.